So let me go to our next speaker, Professor Ebony Boulware from Duke University Medical Center, who will speak about how translational research platforms help to untangle disparities in chronic disease in the individual, provider, system, and community levels. So Ebony, you can go ahead.
Thanks so much. I hope you can hear me. I'm going to pick that as yes. Good.
Yes, we do.
So I really appreciated that wonderful presentation just prior to this. And this is going to be really taking things from the molecular level to a very macro level to really talk about the challenges. And I'm going to really be talking about community health equity and try to apply it to this context, talking about how we can leverage data that we have to not only work to intervene to achieve, try to achieve community health equity, but also how we can use data that we have to study community health equity relative to this, to aging and dementia. I'm going to talk to you a little bit about some future directions and applications for research. So this is, I believe you may have actually talked about this yesterday, maybe even earlier this morning, but this is a figure that comes from the MMWR out of the CDC that looks at Alzheimer's, average annual age-adjusted death rates for Alzheimer's disease per 100,000 population by county in the United States. And there are a number of maps like this for numerous conditions across the United States. And when I look at these maps, and I think it's just as fascinating to me because I work in the area of chronic kidney disease and hypertension and diabetes and don't work in this area for Alzheimer's disease, but it's striking to me that Alzheimer's deaths have very similar patterns as other chronic conditions, which are associated with aging as well, as the prior speaker just said. But what's fascinating about this map is that you can see that there's clustering of age-related death rates from Alzheimer's at the county level, well, regionally. And then you can see that, among certain counties, start with darker areas having higher prevalence of hospitalizations or death rates, and lighter areas being areas where there's fewer. You can see that there's clustering in certain regions of the United States. And what's also very interesting is that there are some counties which are just adjacent to others where there are very high rates and then very low rates. So it speaks to the clustering of conditions at the community level, at a very macro level. And we start to think about what fuels these types of community health inequities. And there's a lot of work that's been done sort of looking at whether health inequities, in particular when it relates to certain chronic conditions that may be drivers for dementia, may be related to sort of dissemination of evidence-based practices or healthcare provider inertia or patient preferences, whether people are able to take medications. But then there's a whole area that I think the prior presentation was really discussing at a very molecular level of what are some of these social environmental contextual factors that could also influence things at a number of levels of human experience and human biology. And those include where you live, what your social environment or contexts are, and a number of environmental exposure, environmental factors that people are exposed to. And this is this is a depiction of neighborhood deprivation. It comes out of Dr. Amy Kind's work, and it's neighborhood disadvantage index by county that also shows where it's an index of, I believe, about 11 different variables such as education, income, employment status, a number of environmental variables that indicate a neighborhood's deprivation in terms of the kinds of resources that are available to a neighborhood, where the red areas are areas where there's most disadvantage and the blue are where there's least disadvantage. And similar to the other map, you see that there's this clustering of disadvantage in regions of the United States, and then by neighborhood, by either census block group, by census block group, and it's similar county by county. You see areas where there's very much dark red, where there's a lot of disadvantage, just next to areas where there's blue, heavy blue, which there's least disadvantage. And so it just brings out that a lot of these contexts that we're thinking about, where we're trying to link things, social environmental context to biology, that they are not just happening they're happening at a national level, they're happening at a regional level, and they're happening at a very local level. So understanding individuals' contexts at all of those levels would become relevant. So, what makes one community healthier than another? Is it that the people that live there, just their general demographics, or are there other factors that we need to be measuring? An economy, built environment, availability of healthcare services or public health, education, housing, safety, social capital, or cohesion? I was listening, with very much interest to the prior presentation talking about structural racism and the experiences about how that might have different effects on biology than other types of influences. And there are elements that are in all of these different factors that manifest through that structural racism at a societal level manifests through. So when we're trying to measure things like that, we need to be taking into account all of these different factors, particularly when we're looking at these macro level clusterings of conditions. And I like to think about health inequities as in context of this ecological model, which I did not develop. There's many different ecological models out there, but it just demonstrates the link between what we're seeing at the cellular level to what happens in the community level, and how those things play together on health and well-being. And in this model, the early pathways, the genetic biological pathways, are determinants of health and wellness, as are individuals' sort of biological responses or physiological responses, such as hypertension, hyperlipidemia, et cetera. But then also their individual behaviors and attitudes play a role in their presence or absence of illness or well-being. Their individual demographics are influenced that as well, primarily because those are related to physical, social contexts and institutional contexts. For example, if we were thinking about structural racism, for example, that has a very big influence on where people live historically, based on our legal system and our system of segregation in the country, as also banking and investment practices that have been well documented through practices like redlining that began in the early 1900s. But thinking about the people's physical context, including from their neighborhood standpoint, including building quality, pollution, business transit access, cleanliness, their social relationships with the community in terms of how much civic engagement is there within a community, how much investment is there in a community context, things that influence collective efficacy, poverty, and then at the institutional context, the economic system, the legal system, and then social conditions and policies. The point of this being, and it's now increasingly believed that these fundamental causes, the social and physical context, actually may make up 50% or more of individuals' well-being, health and well-being. So that when we're thinking about health inequities in particular, it's very important to look at the biological processes and how things are happening, why they're happening at the molecular level, but then many of those drivers and mechanisms actually happen at the macro level. And so very important to keep that context in mind and think about that as we study these phenomena. So how do we study these phenomena where we have, these large macro contexts that seem to be associated with a number of different conditions, including conditions that are associated with aging. And that's really been sort of the big thought, the big sort of vanguard of thinking. So this is what people are really working on at the level of among investigators who are studying health equity. And a few years back, there was a think tank at NHLBI that was really talking about how to move the needle forward in terms of the types of research that could be informative with regard to social and environmental contexts and health. And a number of recommendations came from that, including developing transsectoral multidisciplinary strategies with the concept that there's a lot that we're studying within the biomedical research, health sciences, but there's also a lot to be learned from social sciences and other disciplines that have been thinking through many of these determinants of health and well-being as they relate to health equity, and pulling those together important. I'll also talk a little bit about the transsectoral approach, but a lot of the influences on these health determinants do not lie within an individual. They occur across sectors of the society. And so engaging multiple sectors in health equity work is very important. Incorporating multiple level considerations for research, as I just pointed out, with that ecological model being very important. And that doing that kind of work requires new platforms to promote system science approaches. And that also then requires integrative new data sources that could then bridge these stakeholders and other types of scientists to build research capacity. So the question is how to do that and who's going to be involved. This is skipping ahead a little bit, but it's really, I'm going to kind of talk about the bigger picture and then kind of work way back to sort of the data elements. But when we think about how are we ever going to achieve health equity? So if we're thinking about in the context of dementia or conditions of aging, we're doing this work steadfastly to identify mechanisms. But once we identify mechanisms, what are we going to do to create the actual health equity or improve health? And some of it will happen within healthcare and within public health and within our science. But most of the interventions that will address these macro level factors happen outside of the healthcare and public health arenas and require other sectors of society to get involved, including government, community development organizations, nonprofit, business sectors. Those are the sectors that influence things like the built environment, education, housing, the availability of healthcare services, and social capital. I'm going to talk a little bit about some work that we've been doing to map data in the healthcare sector to contribute to community health equity efforts. We're working our way towards conditions of aging and here at Duke, but I want to talk about the way that health system data can be used not only as a community asset, but also an asset for discovery for investigators. So, you know, health systems, when individuals go and receive healthcare, there's data that's generated, and those data actually, including information about where they live. So it's relevant to developing these maps. These data can be aggregated and mapped, and they can be used to quantify health inequities at the neighborhood level. They can be used to identify community health concerns and potentially even exposures that might relate to those concerns. And they can also be released for public consumption so that these other stakeholders who influence the determinants of health at this macro level can be engaged. They can also be analyzed for discovery and interventions. And we've been doing this in Durham, beginning to do this over the past several years in North Carolina. And if you're not from North Carolina, then these are just some brief statistics on Durham County and North Carolina. North Carolina is 36 overall in health in the United States. Durham County, where Duke is located, is the 6th largest county. It's fairly ethnically and racially diverse. It has quite a bit of socioeconomic diversity, with 16% living below poverty and 20% above, with an annual income of above 100,000. And what we've been doing is trying to utilize data from 2 healthcare systems in Durham, North Carolina, who are committed to improving community health with a long history of collaboration and engagement with Durham. And that includes Duke Health System, as well as our very close partner, Lincoln Community Health Center, which is a federally qualified community health center. And 85% of Durham County residents approximately have received healthcare in some form or fashion in one of those 2 health systems historically, which provides an opportunity to leverage with community permission the data that are in the health systems to look at determinants of health. And so through a joint effort with the Durham County Public Health, a nonprofit called DataWorks, and Duke Health and Lincoln Community Health Center, we've been creating reports on community health and democratizing those data to inform healthcare priorities. And these data are broken down by some basic social identifiers, including race, ethnicity, age, gender, and geography. And the way this process works is that individuals actually come into the health system. Those are the individuals in the middle box, and they get healthcare at one of the two health systems. The health systems generate reports on the prevalence of conditions. Those reports are solicited actually by our county public health department. And the county public health department takes those aggregated data at the community level about health, sends it into the public sphere, and then that group actually develops some maps. And I'll show you an example of some mapping of conditions locally in Durham Health, so that it can be used again by the public and the healthcare sectors, public health sectors, but also a number of other sectors for intervention. And so this is a map on the left-hand side of diabetes rates among adults in 2017 by census block group in Durham, where the darker blue areas are areas where there's higher prevalence of diabetes, and the lighter areas are areas where there's lower prevalence of diabetes. And we've begun to do this type of mapping for a number of conditions. And if you go to this website, Compass, it's a Durham Neighborhood Compass, you can see this for yourself. There are a number of maps that are there where you can look at the prevalence of conditions by neighborhood in Durham. And we've slowly but surely been adding a number of conditions. We actually have more conditions right now than the Compass is able to accommodate. So we're going to be democratizing it probably through some alternative methods to the community with Duke and Lincoln support. But on our list is Alzheimer's disease. It's not there yet. But a number of conditions across the lifespan that we're in the process of mapping. And what's great about this is not are we mapping these, we've contributed health conditions at the neighborhood level for the health conditions. You can see a map of diabetes or those other conditions, but you also can see at the same level of a specificity data on the individual's living context. So civic engagement in the form of voter participation, demographics, education, environment, health, housing, infrastructure, and amenities, and safety. And so there's a number of maps there. So you have then a juxtaposition of and these data are downloadable and they're linkable all at the level of the neighborhood. So you have a juxtaposition of data that look at health and health conditions, at least prevalence of health conditions, and also information on these social and environmental determinants of health. And this is the kind of data that are there. For example, civic engagement, one proxy for that is primary and general election participation. These data come from both local data that can only can be obtained locally at this point, and as well as national data. So data on demographics rely on national data resources such as the American Community Survey and the US Census, but data that are local around things like civic engagement or the economy, which would be represented by things like residential and commercial building permit values or occupancy rates, land use diversity, that comes from city county inspections department, county tax administration, even the county sheriff's office. There's data on education, including child care centers availability and the percent of adults with bachelor's degrees. There are data on environment, such as automotive code violations, impervious areas, which is the amount of concrete that are in an area, tree coverage. These are things that are obtained from both local and national data. You can look at housing, including how many cost burden mortgage holders are there in an area, summary ejectments or evictions per square mile. You can look at infrastructure and amenities, such as whether homes are near pharmacies, grocery stores, fast foods, bus stops, and you can look at crime data. And what's very important here is that the data are national and local. Those national data, when you look at the county level, you can only get so granular with regard to social and environmental determinants of health. You really need these local data to enhance the context. So we democratize these data for the purpose of fostering a common understanding about local community health equities, not only within healthcare and public health, but also to put the data in the hands of stakeholders, both, community residents, but also the stakeholders that can change these social environmental determinants. It's very important because if we're looking at these as mechanisms for health and wellness or disease, we need to understand what the likely interventions are going to be. And if the interventions are going to happen at a macro level, then we need to begin to inform community stakeholders that are the interveners about these risk factors for poor health. So in research, we can take this same database, this same data platform where we're using to sort of let people know about it, and we're beginning to use it to begin to understand things, how these social environmental determinants of health are related to the prevalence of conditions. And so this is some work that I'm working on with a colleague, Danushika Mahatage, who's a faculty member here at Duke in nephrology. And we're looking at the chronic kidney disease prevalence among adults in Durham County and how they may be related to social environmental determinants of health. And so this is a map of chronic kidney disease among Blacks in Durham County in 2017, where the darker areas are higher prevalence of chronic kidney disease and the lighter areas are areas where there's less prevalence. And what we're doing are factors that are associated with redlining are actually structural racism. And seeing if they are related to CKD prevalence in Durham County. And some of those constructs include evictions, which would be a measure of housing and economic stability, median household income, which would be a measure of wealth and opportunity, commute times, impervious areas, which would be measures of the quality of the built environment. Again, election participation, which would be a measure of political disenfranchisement or whether or not one's priorities are likely to be reflected in community policies, looking at violent crimes, which would reflect either a lack of safety or excess criminalization in a community. We've begun to look at these constructs and their association with a community being high CKD prevalence versus low CKD prevalence. And our early work finding that there are associations between things like violent crimes, commute times, social capital, household income with CKD prevalence. So the value of these types of analyses, which can be applied to any condition, would be to help identify these macro environmental mechanisms as potential targets for interventions and facilitate the cross-sectoral insights on ways to develop and target those mechanisms. Provide a framework for work that can extend beyond sort of individual frame of health and wellness to a framework that looks at all of these levels of influence more simultaneously. And then ultimately, this kind of work, of course, as I said before, would be translated by these other sectors that influence these social and environmental determinants of health. So government officials and policy advocates, business leaders, healthcare providers, community-based organizations, individual residents, and researchers. And I think the key is that the reason I put this here is that we will likely develop treatments, but as with, for some conditions that are very effective, that we have not, for dementia and other conditions that are more effective than what we have now. But I think we're unlikely to see improvements in health equity unless we address these particular mechanisms. So what we're doing within Duke is developing a multidimensional research data platform to incorporate community contexts and studies of health. And so we have taken our electronic health record data from Duke Health, all of it, and also from Lincoln Community Health Center. And we've created a data platform, essentially, where all individuals' data are there, and they are geotagged by individuals' neighborhoods. And what we're able to do using a common data model is link other types of data to these data so that we can then begin to link in the geospatially enabled social environmental community data, like the data I showed you, to every individual seen at Duke and Lincoln. as well as other data sets such as insurance claims data and other types of data that are of interest. Eventually also looking to link these to biospecimens and additional types of data, and then be able to generate specialized cohorts of individuals so we can study these multiple levels of influences on individuals' health that contribute to these community level health inequities. Ultimately, what we have been doing is providing annual updates to the community on the existing conditions. We'd like to expand the number of conditions, including conditions that are conditions of aging, to this resource in terms of the democratized data. We'd like to continue to expand on the internal work that we're doing through this data resource, the Data Mart. Right now it's called our Clinical Research Data Mart. Then we'd like to also work with community members to think about how to develop new interventions that can help us intervene on some of these determinants of poor health, and ultimately, hopefully, lead to sustained uptake of effective interventions in the community. So I think the ultimate goal of my talk, which was very high level, was just to entertain how these new data platforms can really lead to creative transsectoral multidisciplinary strategies to improve community health equity, including in aging, and that utilizing these new data resources, we can begin to think at a very macro level on how to promote health equity. And so that's really my summary. I think we need a unique lens to do community health equity research in all areas. In order to do this work well, we need to leverage cross-sectoral connections with other sectors and the data that come out of those other sectors to really think about how we can drive community health equity interventions. Utilizing the data that we have, not only putting it into the hands of these other sectors, but also into the hands of researchers, I think will facilitate a lot of synergies. And there's I think, a very exciting next generation of research that can come from this kind of work to improve community health equity, particularly around aging. There are a lot of partners involved in this work. And so I'm going to close there, but say thank you.
Thank you, Professor Boulware. It's really, really exciting talk, and I learned a lot about different aspects of those data and so forth. And I really think this, as you put it, data democratization is a key aspect of all of this, like access to data to make this information accessible and available for different types of stakeholders, researchers, and so forth is really, really key here. Okay, I see immediately we have two raised hands among the panelists, and let me just go from the top. I don't know who was the first, who was the second. So Harvey, you can start and ask questions.
Yeah, Ebony, great talk. Any possibility of incorporating the VA data for those Durham residents who use the VA system, which would sort of complete the total package of all Durham residents?
We would hope to be able to do that. I think that makes it at a local level, that's difficult because the VA is national, of course. But there are national efforts, Harvey, ongoing right now to connect multiple systems. There's something called right now in the era of COVID called N3C, where every single academic institution, all their health records are being pulled in to be able to do this kind of mapping around COVID and link all these health record data. And I think the VA probably would get into that game at the national level, so that eventually I'm anticipating that there will be numbers of types of information there. But you're right, we're missing pieces. And additional, there are other health systems there, so ideally we get as much data together as possible.
Great.
Thank you. And Alexander, you can go ahead and ask.
Hey, really great talk and fascinating site. Actually, I just checked it. Let me share my screen with you for a second. And what I was very surprised is this number. This average age of death in Durham County, which is well below that in the United States. Well, basically by 10 years. Do you have an idea why is this?
Well, so I think part of it, I mean, I don't know why, but I would think some of it is related to demographics. You know, we do have probably, you know, we have pretty diverse population. So it depends on the health of those individuals. So if we have, I don't know a lot about it, to be honest. I'm sure epidemiologists have looked at it, but I think if you have, you know, high proportions of Black individuals, you may, and people who are more subject to health disparity, your average age, you know, obviously goes down. But that, you know, could potentially explain some of it.
Are those deaths of Durham County residents specifically, or deaths occurring in Durham County?
Durham County residents. Of those of, yeah, of Durham County residents.
Okay, I see Igor raised his hand. Igor, go ahead.
Thank you. Thank you, Ebony. Very, very interesting and new for us. So do you think that Medicare data, we discussed a lot of applications from Medicare data. Do you think it can be helpful for analysis of Durham County and joining with your data?
Yes, absolutely. And we're going to seek to try to link Medicare data to these data because you just get more information about healthcare utilization. So the individuals, so the data that I showed you from Duke and Lincoln are only when they come to those healthcare systems. But of course, individuals are using all kinds of different healthcare systems. They might use UNC, they might go to Wake, they might go to different places that are locally. So Medicare data will help fill out on healthcare utilization and conditions that people may be seen for, but not in our systems. So that's very useful to bring that in.
Thank you. It looks you will know everything about health in Durham County soon.
We would hope to. We would hope to. But I think also what I would love to see is building the biological data as well. You know, to have biospecimens and some of the other data that are there, so that you really could get multiple layers. The macro level is great, but then you still need that molecular level, that micro level, the cellular level, to really get that full picture. So that would be the full vision, and I think we're making our way there.
Okay. Do you think to start working with other North Carolina counties?
Yes. So there's been a lot of discussion. It's easier said than done, but there are interested investigators across North Carolina that would like to get into doing a similar thing. We've been fortunate in Durham to be able to get to this level. I think we're actually have more going on in this arena than many areas in the country, most areas in the country. But we'd like to expand this to see if we can get some sort of a statewide platform going. There are some statewide, so there is a Health Equity Council for North Carolina State that has some data on health inequities. It's more based on questionnaire data. Doesn't have this health system level data that are there, but we'd like to build off of that platform, seeing if we can build out more of this for our whole state.
Thank you.
Thank you, Igor, for your questions. You can lower your hand now. Just okay. All right. So, any other questions from the panelists or the audience? Okay. So, seems we don't have any other questions. Okay, let me then thank you, Professor Boulware, for your talk. It was very, very informative indeed. As Igor mentioned, it's new for us and it's really exciting. So that such kind of developments are happening and it becomes a reality that we will eventually know everything about health in Durham County to start with, and then hopefully some neighborhoods, and then maybe eventually in every other. That's really great. Thank you so much.